Hey guys, thanks for tuning into Straight to the Core, an in-depth, no-nonsense look at all things physical therapy, wellness, and the business of being healthy. We are your hosts. I'm Claire. I'm Mark's wife.
And I'm Mark. I'm Claire's husband.
And today we are talking about an injury that we've been seeing more and more at the clinic, which is in generalities is shoulder pain. But how do you know that you have shoulder pain versus a shoulder injury? Because I think that is with just like the prevalence and the commonality of like a rotator cuff tear, like worst case scenario, I think that's where people jump to a lot when they have any sort of shoulder pain, even from like the initial onset.
Yes, we have learned that 70% of people at some point in their life will have shoulder pain.
Yes.
Equivalent to 4 million people per year in this country, which is not insignificant.
Yes. And I mean, I think especially on your dominant side, like shoulder pain can flare up so rapidly that people all of a sudden, you know, we hear this mechanism of injury all the time is that there is no mechanism of injury, is that they did something, maybe they're playing pickleball or they went to the gym or, you know, they were traveling and then there was nothing at the moment. There was not that like specific moment that they say, yes, I pinpointed exactly when that injury happened, but they started having shoulder pain and then it flared up rapidly and all of a sudden they're thinking worst case scenario, oh my gosh, I'm about to have shoulder surgery and be incapacitated for months on end.
Correct. And a quick note, at least 30-40% of the people that come in with shoulder pain, it's actually trap pain.
Right.
A lot of people misconstrue the trap for your shoulder pain. That's actually just part of your neck. It does act on your shoulder as well. But I do get a lot of the people, oh, my shoulder hurts right here. And they're pointing to their trapezius, not their actual shoulder joint.
Correct. So starting at the very beginning, your shoulder is what we call a ball and socket joint, even though it's not really, right? Like your hip is definitely more of that like ball and socket stability is given by the actual joint structure. What I like to say to a lot of my patients is your shoulder is very much like a golf ball and a golf tee in terms of the actual joint congruency or like how the joint is built from a structural standpoint. And almost everything that's controlling your shoulder is soft tissue related. So you have your scapula, which is the technical term for your shoulder blade, and then you have the head of your humerus, which is the upper arm. And they come together to make what we consider your glenohumeral joint, or your, in layman's terms, your shoulder joint.
Yeah, and it's inherently a very unstable joint.
Correct. So you have your joint capsule, you have your labrum, and then you have a whole bunch of muscles that help to either stabilize your shoulder, move your shoulder, or a combination of both. And the four big ones we refer to as your rotator cuff, not
your rotary cup.
Yeah, which
my goodness gracious.
I smile. It brings me great joy actually when someone is like, my rotary cup. And I feel like at some point, one of our parents probably said it too, and it's very endearing.
That's stuck.
Yeah.
Yes. It's your rotator cuff, C-U-F-F.
Yes, and your rotator cuff is a series of four muscles that their primary goal actually isn't to move your shoulder, although they do. The primary goal is to add dynamic stability to that glenohumeral joint. So they are actually kind of like suctioning that humeral head to that, what we call your glenoid fossa, which is just basically the socket of your shoulder, happens to be connected to your shoulder blade.
Correct. And they act more aggressively for stability once you get over 90 degrees overhead. They're less movement oriented and more stability oriented after 90 degrees of elevation.
Correct.
So approximately your shoulder level.
Yes.
And above.
So I think the reason that we wanted to talk about this is that we've seen kind of an increase in rise of this. And obviously being active is hands down better than any of the alternatives. But sometimes you have people who are trying to make positive life changes. They're going to the gym, they've increased their activity level, and all of a sudden they're like, I think I really hurt my shoulder. The general consensus I feel like that we see a lot of that we can calm people's fears is not that they've somehow inexplicably in their sleep or without their knowledge hurt one of the rotator cuff muscles, tore their labrum or anything like that. Probably the most common thing that we see is what we consider secondary impingement. Mm-hmm. So secondary impingement just means that, in a very, very long story short, is that your shoulder blade and your shoulder are not kind of like moving in rhythm with each other.
Correct. Scapulothoracic dyskinesia is the nice term for medical people. But what that means is they're not talking to each other in a very productive way. Really, that's what it is. So when you go up overhead, things need to glide, things need to slide, things need to be stabilized overhead. And if there's something in the mix that's wrong, you're going to have some compression in a tissue that's not designed for compression. You'll get irritation, and then you'll get usually anterior shoulder pain. It's not always anterior, but very much a posture and disuse or misuse type of injury.
Correct. And very, very often something like this comes from like a compensatory pattern, right? Or a compensation pattern that you might not even realize that you're doing. Mark touched on it earlier, the trap or the upper trap or trapezius can very much kick in a subconscious way to elevate and protract that scapula. So essentially it's trying to bring your shoulder blade up and forward, which doesn't necessarily sound like it would be a problem other than the fact that you have this tiny little tip of bone on your shoulder called your acromion, which if your shoulder blade starts to come up and forward, that tip of your shoulder also comes up and forward and can compress or kind of pinch one of your rotator cuff muscles.
Yeah, I would say one of the biggest issues is people are more trap dominant because of posture, or what they're doing in the weight room is too much shrugging. When elevating the arm overhead, the shrug of the upper trap is dominating.
Right.
And the mid trap and the low trap, they're stabilizing to the rear, into retraction or pulling back together is just not keeping up with the equation very well.
And I think there's also the thought of like the vanity muscles, right?
Yes, of course.
This is probably a little more male dominated than female dominated, but it's cool and it's sexy to do bench press or overhead press or bicep curls. It's not as fun to sit there and say, I need to do rows, I need to do lat pull downs, I need to do, like a lower trap activation exercise. It's just not cool.
Very few people would balance them correctly because the muscles you don't see, you don't care about as much, but they're equally as important, especially all the time we spend heavy benching. You have to row just as much as you bench. You have to press and pull at the same rate. The old adage was 2 to 1, but I don't think that's really fair.
No, but even
it should be 1 to 1.
Just doing like a push-pull type of progression in your workout, right? So for every time you push, you have to do a pulling something. And it's not, like I said, it's not cool and sexy. Everybody wants to push a sled. Nobody wants to pull a sled back, right?
Well, because we can push more than we can pull, technically.
Exactly.
And our bodies are more designed to push than pull, and more sports are pushing sports than pulling. I can only think of very few pulling dominant sports, other like wrestling.
Rowing.
Row.
That
would be, yes. That's very, very dominantly pulling. But in general, most are forward movement pushing sports. And so because of that, you are going to get a lot of overuse and overcompensation injuries unless you're specifically, trying to overcome that.
What's in that glass? What's in that cup?
Yeah, right.
Or maybe you haven't had enough of it. No, and I think it's probably fair to say, and please correct me if you think, Mark, if you have a different opinion. I think it's probably fair to say that a lot of people who have this, like what we would consider an insidious onset of shoulder pain, probably have like the prime works of things going on before that.
And Insidious is not a bad movie from like 5 years ago. It is, the meaning of Insidious
I thought it was an okay movie.
I don't know that you've actually seen it. It's too scary for you.
No, I felt like I was proud.
Yeah. Anyway, it means that it's coming on with an onset that's more gradual, without a trauma, without a fall, without a real reason. I don't know. It's been bothering me for 4 to 6 months. I can't remember what happened.
Right. I just kind of woke up one day and I realized that it was bothering me.
Coming and going, but now it just won't leave. It's growing or not going away. That's more of an insidious onset. If I fall down the stairs for some reason and grab the rail and now my shoulder hurts, that's not insidious. That's an acute trauma.
Right.
Totally different.
Or even if you do have something that's out of the norm of what your regular routine is, right? Like, oh, I don't know, I was traveling, I was in a plane seat, I was like pulling my luggage, I was putting overhead bags.
Overhead bags get people a lot because it's awkward, it's heavy, you're in a hurry, people are like pushing you to get your butt moving, and you're like, oh.
Exactly. But not like a huge, I can tell you exactly the moment that something went. That can also be a little bit more of an insidious onset where it's not like one specific thing all of a sudden put everything in motion. It's the groundwork of things maybe have been going on in the background.
It's the culmination of things. And I tell this to people a lot. They'll have anterior shoulder pain, and then I work on the shoulder blade a lot on the backside because that causes a lot of issues in the front. And it's a chicken and the egg phenomenon for a lot of people, much like the hip and the knee relationship. You don't really know which one caused the other one first because you can't follow people around for 6 months and see how they're moving and how they're using it. Usually the area that starts to hurt first is the primary, but that's not always true. Sometimes that's a compensation for something else.
I would agree.
Maybe 40% of the time where you're having pain is not the cause of the pain. Maybe more.
I would agree with that.
Especially
Absolutely.
in the knee, but the shoulder as well, because the shoulder, very complicated joint.
Yes. Well, and I think too that having shoulder pain very often is something that is, like I said, going on in the background, but like, especially on your dominant side, we're so good at compensating. So you might do something, you're like, oh, that didn't feel good. And you just change your way of doing it so that you're not pushing through a painful motion. And then all of a sudden you realize that, okay, well, I've changed how I do something, or I'm changing how I'm moving so much that all of a sudden, like, there is no pain-free version of doing it. And you're like, oh, my shoulder just started hurting, but it didn't just start hurting.
Well, then now my trap hurts. Now I have headaches. Now I can't sleep. Now I feel it when I'm working on a computer all day with my mouse hand being my right hand. That hurts.
Yeah. So what are
how do we solve these problems?
What are some things? So obviously the number one thing is diagnostic. And I'm not just talking about like we're throwing everybody to go get an MRI or an X-ray. Most of the time,
X-rays are generally worthless.
Well, in this particular case,
Yes,
I mean,
in this
you're
case.
looking for something like a primary impingement, like a bone spur that's on your acromion. Having something like a clavicle fracture or something that you're
trauma,
like, oh gosh.
Sure, an X-ray is great, but if there's no mechanism.
Right. But diagnostically, and I know there's this huge movement in physical therapy right now that like special tests don't tell us that much. And I would say probably like if you're good at special tests, it's kind of leading you towards one direction or the other, but there's very few things where you're like slam dunk, man, like yeah, I mean, there's something in the PT world for your shoulder called an empty can test that basically, if you're watching on YouTube, you'll see this. If you're listening, you won't have any idea of what I'm talking about. But you hold your arm out and you rotate it so your thumb is pointing down.
Like you're dumping out a can to empty it.
And then you try to basically resist that. Well, if you can't do that, that's like a slam dunk, but you don't need that specific test to figure out that you might have a rotator cuff tear. Like there's some other things where like, I literally can't move my arm.
Well, and if you have a lot of pain, it's going to present as being weak, which it actually might not be weak. Pain makes you weak because your body's trying to protect itself.
Correct.
So it could be pain-induced weakness, and I write that on evals all the time. Of, 3+ out of 5, but that's secondary to compensation of pain pattern.
Absolutely, yeah. Same. Oh my gosh.
Oh my God.
Mark and I don't read each other's documentation.
Best
friends.
Yeah.
We don't read each other's documentation very often, so when we find out something like that, I never read his notes, actually.
Weakness is not usually the issue more than using improperly or leverage improper.
Exactly. But so diagnostically, when we're looking at those things, like, okay, maybe they do have an X-ray, maybe they don't. Maybe they do have an MRI, maybe they don't. And something diagnostic imaging wise, like an MRI, doesn't necessarily tell us what's painful. It just tells us what's there, what's not there, what's intact, what's not intact. So let's say all of a sudden, out of the blue, you have shoulder pain. You don't have a specific traumatic mechanism of injury. You just kind of had this insidious onset. You rush to your doctor because you're thinking worst case scenario, X-rays negative, MRI negative. But you're like, my shoulder hurts so bad. What's happening? Now, diagnostically, there's a couple of things that could be happening, right? Like we know it's soft tissue. It could be an irritation of one of the rotator cuff tendons. It could be the secondary impingement. It could honestly be something as generally benign as what we were talking about before, where your shoulder blade and your shoulder, or your shoulder blade and your glenohumeral joint are just not talking to each other the right way.
Yeah, and they're not in a very symbiotic relationship. And I see this a lot with my lifters, male and female, but male dominant because they're so dominant on pressing. A lot of anterior bicep pain presents as shoulder pain because of the long head going into the shoulder joint itself.
Speeds test.
Yes. Well, I think a lot of people do dips and behind the neck press and a lot of forward pressing that is very dominant, and there's just no balance on the backside. And that gets so much more impingement. Or, wide grip rowing, wide grip benching. It's
well, and I think
unstable.
Especially in the young population, going back to what we touched on before with lifting, is that like if you're short on time, are you really going to sit there and be like, oh, I have to do a row after I bench? No, you're in and out of the high school weight room. You're like, yeah, let's max out on bench. No one's maxing out on a row. No one's maxing out on a lat pull down.
Nor should you really, but maxing out really is not important anyway.
And I don't want to harp on this too much because there's definitely things that you can and can't control with it. But like postural issues
is really
is
large.
Huge,
Yeah.
yes. When I say I don't want to harp on it because there's things you can and can't change, like sometimes people's posture or people's sleeping posture or something like that, you're like, yeah, I get it. Like that's how you sleep because you're comfortable with it. And there's plenty of crummy postures out there that aren't painful. Yet. But especially with this rise that Mark and I have seen incidence-wise in terms of what we've seen at the clinic, then I don't think that there's probably...
I'm going to blame also cell phones and iPads.
I don't think that there's probably a disconnect between an upswing of how much, especially young people, have those tablets and those phones in their hands.
Yeah.
And this incidence of shoulder protraction, kind of that like
rounded
neck,
forward position,
forward head
neck forward
position.
position.
And all of a sudden they also have this increased incidence of shoulder pain.
Yeah, and you're working on symptoms initially when you come into the clinic and seeing one of us. We try to get rid of your symptoms, but the symptoms alone do not solve your problems, obviously. So you have to fix the positioning of the shoulder blade and how the rotator cuff fires.
Right.
And the structures around it. And because it's unstable, it's a fairly complicated joint. So you have to do a lot of different things depending on how you're using it in the weight room or your sport. Overhead sports are going to be the hardest.
Now, shoulder pain, like you said, is that shoulder pain very often comes after the fact that there's already been things that are happening, right? So you can have irritation to tendons, you can have an imbalance of strength or mobility that is relatively pain-free until all of a sudden there's pain that's with
until
it.
It's not.
Exactly. And you're symptomatic, but that doesn't mean that the issue just started when you think it did.
No, and a very small amount of irritation can cause a lot of pain in your shoulder because it's an enclosed capsule. It's a small capsule. If it's on your dominant arm, which is probably 60 to 70% of all shoulder pain, you're using it all the time.
Right.
And you can't get away from it.
Right. And you think, oh, I have some shoulder pain, I just won't do dips. Or, oh, I have some shoulder pain, I just won't do this. But all of a sudden, you can't pull up your pants going to the bathroom.
Or you can't sleep on that shoulder.
Right.
Or you can't sleep on the other shoulder because the other shoulder hangs down.
You can't reach to put your seatbelt on. You can't reach into your back pocket. You can't put your arm in a sleeve because you have pain with all of these things.
Yeah. So there's a lot of things going around, but like the biggest thing is because there's so much motion available at the shoulder joint because it's designed to be mobile, not strong. Strengthening it is very complicated. There's a lot of different ways to strengthen it.
I agree.
Once it's ready to be strengthened.
Right. And I feel like that is one of those things that the internet has kind of done us dirty, is that people are like, here are some strengthening exercises for your rotator cuff.
Yeah.
And how many times have I seen somebody at the gym holding a 2.5 or a 5 pound plate or weight, and they're just like, oh, extra rotation extra rotation in 90 degrees of flexion, extra rotation of 90 degrees of abduction.
Mind you, their shoulder joint is protracted forward completely the entire time with no posterior engagement at all.
Now, post-surgery, we do see weakness as an issue, obviously, because a muscle has been repaired, a tendon has been repaired. You're specifically trying to activate these muscles. I would venture to guess, though, that in the realm of like non-specific shoulder pain, weakness is pretty far down the list of things that I'm really concerned about.
I would agree. I think weakness is like a secondary issue, maybe a prevention issue, but the acute issue is more positioning and mechanical.
Agreed. So things like upper trap hypertonicity or tightness in your upper trap, tightness in your pec, tightness in your lats, all those things that are trying to pull your shoulder blade forward. Those are big culprits that I usually look at in terms of mobility-wise, compensation pattern-wise, before I'm sitting here saying, like, gosh, your supraspinatus is weak in external rotation at specifically 90 degrees of abduction.
Yeah, and I would say, with a lot of the lifting population, which, the foundation of all sports is lifting and conditioning of such, the technique of pressing needs to be examined. How are you pressing? Do you shrug when you press? Do you overhead press? Do you have that rounded position? You could solve all these person's problems, and if you don't really address what causes them to compensate or what causes the programming or the exercise selection, it's going to come right back.
Exactly. And I think that's something that's good you brought that up. That's something we see a lot of too, is that people will say like, oh, I went to the gym and I had pain and then I didn't do anything for 3-4 weeks and it got better. Well, it didn't necessarily get better. Like your pain got better, but the actual issue didn't go away. You just didn't piss it off in that specific position.
Resting when you're injured and expecting it to get better is like not driving your car when it makes a weird noise, because when it's not on, it doesn't make a weird noise. Right. It's fine.
Or the warning light didn't come on for the last 4 weeks. That's because I haven't driven my car in 4 weeks.
So turning up the volume on your stereo when your engine's making a weird noise just distract you so you don't hear it anymore. It doesn't change the fact that you have a problem. So taking time off is not really the best way to solve a problem.
I honestly can't remember if it was a friend in high school or if it was my sister, but like put a Post-it note over the check oil or the check engine light just to be like, well, I don't know, the light didn't go.
It's like if you're mad at your spouse and you're like, I'm going to like leave for 2 weeks, I'll come back and she won't be mad at me anymore. Yeah,
well,
probably not a good idea. I'm just saying. So ignoring problems never solves them, or extremely rarely solve them.
Right.
Makes them worse, actually.
So things for prevention, things for treatment. I also need more. Probably the biggest things that I would want somebody to take away from is
number one, positioning for me.
Yes.
Positioning.
Yep. I would agree with that. So, and maybe not even positioning, but like positional awareness. So catch yourself. Like, are you, when you're sitting on the couch with your phone in your hand, are you like slouched forward with your shoulders just like disgustingly forward?
Chances are you are doing this 100%.
Yes. I mean, I try not to chastise people's posture because I don't think that my posture is that great. But if that's consistently your posture, there's a saying that like the best posture is the posture that's always changing. If that's a position that you can get in and that you're comfortable and you spend 15, 20 minutes in it, that's fine. If that's the position that you're in and you happen to be 14 years old and female and you don't move out of it ever because that's your position during your school day, that's your position when you're laying in bed, that's your position when you're scrolling on your phone, then that becomes a problem.
Yeah, and it'd be easy for us to spout off a bunch of great mobility exercises to do, but giving somebody just a blanketed mobility program when you don't know that that's the problem doesn't solve your problem. It could create another problem by having too much mobility. So mobility is rarely the only issue. It can be, but it just depends. So we're not going to give you like a specific recipe because it's not specific to you.
Correct.
I wish I could just be a YouTuber that's like, ooh, these are 5 exercises that solves your shoulder pain.
Exactly. And you'll never, as long as you do these 5 exercises, you'll never have shoulder pain. Sorry, that's BS.
Not possible.
Yeah. Having motion when you need it and stability when you need it are probably the 2 main keys, right? So are you able to put your shoulder blade and your shoulder in a position that's advantageous for you, that you feel stable and strong, but you're mobile when you need it to be?
Correct. And do you do some exercises in the motions that you need for your particular sport?
Correct.
If you're not an overhead athlete, do you need to like do a ton of overhead, heavy mobility, heavy strengthening stability program? Maybe not.
Right. I mean, obviously,
Specific to
an
your needs.
outside volleyball hitter or a setter that needs to have a ton of power in that overhead position. Yeah. Something like an overhead squat, something like a lunge with an overhead stability. Yeah. A ton of kind of like awkward, unstable exercises in that overhead position are extremely appropriate for you. If you are a rower who never goes overhead in that position, then that might not be something that is worth, the juice isn't worth the squeeze to sit there and spend a ton of time
or
in
a power lifter. Correct. My power lifters do not need the mobility of an Olympic lifter. It's a completely separate sport, and one would be good at one thing and one is good at another, but Absolutely. They're not interchangeable, nor should their mobility be also interchangeable.
Absolutely.
Like a swimmer.
Right.
They need a ton of overhead stability.
And even within, if you are a specialist with a specific sport, right? I mean, having the overhead motion of a freestyle versus the kind of like awkward lateral stability needed of like a butterfly swimmer.
Or backstroke.
Slightly different. Yeah,
the backstroke is different too. Mm-hmm. So
which is why we like to see you in person and we don't spout out just advice via the interwebs.
Generic advice with no specifics is borderline irresponsible because you're not getting the whole story. It'd be like saying, hey, my chest on the left side hurts. What's wrong with me? Well, it could be your shoulder. It could be your heart. It could be a tumor. It could be a blood disorder.
It could be your rib. It could be...
Yes. So it depends on the testing and the symptoms and the history and the etiology and all those things combined. So especially with the shoulder, blanketedly giving people programs for mobility and strengthening is fairly irresponsible because if you're strengthening some athletes overhead or you strengthen them without the proper mechanics, you're going to make it worse before you make it better.
I agree. And I think there are certain things that come up that you're like, ooh, okay, maybe this patient has a small asymptomatic labral tear. Well, maybe strengthening for them is super important in very specific positions because they need to compensate for that labrum. Your shoulder labrum, and I think we touched on this with our ACL podcast, your shoulder labrum is very much a seatbelt, right? Like you should always have your seatbelt on, but you don't necessarily rely on your seatbelt 99% of the time because you're controlling what your body position is with the muscles that are controlling you. Same thing with your shoulder. Your shoulder labrum might have an asymptomatic tear that's maybe was there long before you knew it was there, but the actual strength and stability of what's controlling your shoulders, like your muscles, is probably what the primary issue is, either with pain or stability.
Correct.
Yeah.
I couldn't have said it better myself.
Oh, thank you.
You're not so
Thank
bad.
you.
Not so bad.
More than a pretty face. So, takeaways. Shoulder blade positioning, probably shoulder blade positioning over shoulder positioning, but they go hand in hand. Appropriate mobility and appropriate strengthening.
Depending on your sport and particular needs.
Yes. And just like, I guess, situational awareness in terms of, okay, my shoulder doesn't hurt when I'm doing X, Y, and Z, but this is when it does hurt. That will tell you a lot. One of the special tests that I do actually like, and I don't rely on it, but it's kind of like more of a confirmation of what I'm already thinking, is an impingement test, where you basically bring your shoulder up into a position that you know that you're kind of like pinching that supraspinatus between your humeral head and that AC joint. For me, that's one of those things where it's like, all right, is this something that somebody can tolerate, or is it something that is painful like the minute you start getting in there? Which to me just basically says, okay, this is something that's been going on long enough that tendon is super irritated.
Correct.
So knowing like, hey, I can get through 95% of my day pain-free, but there are very specific motions that bother me. I think that's important in terms of shoulder health as well, because that tells you, hey, here's probably what's going on.
Yeah. Yeah.
I couldn't have said it better myself.
Yeah,
Well,
but you
I
did.
did.
You did say
I
it
did.
yourself.
Yes. So that is kind of a very quick,
Very general, broad.
yes, of if I have a shoulder injury versus shoulder pain. Obviously, if you have a very acute mechanism of injury, a fall, a very specific like pop, snap, something like that, you know, going to a PT, going to an ortho.
I got
getting
a question for you.
Yes.
Every direct access patient you come in, they're all shoulders, right? What percentage of people have a surgical injury?
Oh.
It's not that high.
No, it's not that high.
Maybe 10 to 20%. The rest of them aren't even close. And some
Yeah.
of those are on the borderline if you need it or not.
Yeah, I would probably sit there.
So
in
the
that.
majority of shoulder pain, in my opinion, that I see in my clinic with an active population is not a surgical candidate.
Correct. I would agree with that. Now, there are times that there are surgeries that are done that may or may not be like in that moment necessary. And then there are surgeries that you're like, gosh, you know what? Like I'm seeing this patient and they are not going to get better until they have a surgical repair of something.
Or it's, symptom management during a season that's important for recruiting or things like that. Sometimes you try to minimize issues during an interim because careers are important.
Absolutely.
Seasons are important too.
Timing, things like
Minimizing
that.
risk in the future, all that stuff.
Absolutely. So if you or somebody you know is having some shoulder pain and you want a little more information about your specific case, please feel free to reach out to us. We are reached at www.coreomaha.com
on the World Wide Web.
We are on Facebook, Core Omaha, or Core Physical Therapy. Instagram, Core Omaha. And I always say this, we're on Twitter, we're on X, but don't tweet at us because we don't check it.
No, we don't check it.
But there is an account.
All right. Thanks for listening.
Yes, I'm Claire.
I'm Mark.
We're out.